To enhancing quality of life, which will be the topic of the next talk. And I also want to encourage you now to start writing down questions. At the end of this talk, we'll have the Q&A up here, so if you can already start writing questions, passing them down. If you don't have cards, raise your hand so we can distribute them further. So it's a pleasure to introduce Niels Johnsen, who's actually pinch hitting for Dr. Wessels. Dr. Johnsen is a urologist who works at the University of Washington Men's Health Clinic, and a major component of that clinic is actually dealing with quality of life and side effects around treatment for prostate cancer. So welcome.
Good morning. Thanks for having us here. Let's see. There we go. So I think Dr. Wright's talk was a great segue into our discussion here in this talk about sexual and urinary quality of life in patients after prostate cancer. And we know that prostate cancer, it's a survivor's cancer. 95% of people with prostate cancer are alive at 10 years. So doing what we can to improve their quality of life following treatments or even when put on active surveillance is what our goal in men's health is. And we have a saying that we want to just not help men survive, but to help them thrive. So the goals of this talk, we're going to talk a little about erectile dysfunction and definitions of ED and kind of prevalence of ED, and then talk about how ED and urinary incontinence are associated with prostate cancer and prostate cancer treatments. And lastly, to talk about what treatments we can provide for patients who have these adverse events after treatment for prostate cancer, and how we can restore quality of life in patients regardless of their stage, the duration that they had cancer, or even the treatments that they undergo. So before we talk about prostate cancer in specific, we'll talk a little bit about all men and erectile dysfunction overall. So how do we define ED? ED is the inability to obtain or maintain an erection firm enough for sexual intercourse. But I'll add to that when we see men who come in with sexual complaints, ED isn't just a rigidity of an erection. It's how your sexual function impacts your daily life and what sort of bother that has to you. Because that's really what we want to do. We want to identify what a patient and their partner's goals are and see how we can help them achieve those goals. How common is ED? In the general population in men over the age of 20, 1 in 5 American men have ED. That's over 30 million American men who struggle with ED. This is a chart of the prevalence of ED with age. Let's see if this works. Oh, yeah. So if you look at healthy men, which are this bottom line here, as you go up, you can see as patients age, the prevalence of ED increases. And then when you add risk factors, such as high cholesterol, high blood pressure, diabetes, cardiovascular disease, it accelerates the incidence or prevalence of ED in those populations. And then prostate cancer itself is a significant accelerator and amplifier of ED. So what about men with prostate cancer? Why do we see that increased prevalence? So I have less science in my talk, but we'll talk a little bit about the physiology and pathophysiology of ED. So to get an erection, there's nerves in the penis that submit or transmit neurotransmitters that go to smooth muscle cells in the penis. It causes relaxation of those, and then there's increased blood flow into the penis. With that increased blood flow causes an erection, which also helps prevent blood from leaking out of the penis and helps you maintain an erection. So anything that disrupts that neurovascular event can cause ED. So we see with surgery or radiation, you can see what sort of steps in that process can be affected. In surgery, you always hear the urologic oncologist talk about nerves and preserving nerves and nerve damage. So any damage to those nerves can cause problems with erectile dysfunction. Anything that affects the vascular supply can cause problems. And then the penile tissues themselves, if there's disruption in the nerves or disruptions in the arterial blood supply, that can change the structure of those tissues and cause you to be unable to keep blood in the penis and maintain an erection. Similarly, radiation increases your risk of vascular damage, increases some of those local changes in the penile tissues, and also, like Dr. Wright was discussing, androgen deprivation can play a role in affecting your quality of erections. This was a large study that followed men, over 1,600 men treated with localized prostate cancer over 15 years after treatment, and compared sexual and urinary outcomes in men treated with surgery or radiation. And for us who treat men's health issues, the most important thing to us is not whether a urinary problem or a sexual problem is present, but whether it's bothering the patient and is affecting their long-term goals in terms of what they want to achieve after treatment and in their survivorship period. So we'll start with urinary issues. You can see that at 2 and 5 years after surgery, somewhere between 10 and 13% will have bother because of urinary incontinence, or about 2 to 3% of men will have bother from urinary issues after radiation. But when you look at 15 years, there's no statistically significant difference in urinary bother between surgery patients and radiation patients. I will say, as a side note to this, these numbers represent a large kind of population-based cohort of people who are treated for prostate cancer. And so it comes from institutions like the University of Washington that are high-volume centers of excellence, as well as community institutions where they treat maybe a lower volume of prostate cancer. So these numbers may not be representative of what you see at centers like University of Washington and Seattle Cancer Care. And there's multiple studies out there that show patients treated at higher volume centers of excellence likely have a lower risk of adverse effects as it relates to sexual and urinary function after treatments. When we do look at sexual function, and again, patients who are bothered by sexual function after either radiation or surgery, we see that somewhere between 40 and 50% of patients in both radiation and surgery groups have significant bother and often seek treatments for this after their treatment for prostate cancer. So this is a graph that came from that same study, and you can see the red line are surgery patients who were treated with prostatectomy, and the blue line is radiation patients. And you can see immediately after surgery, there's a significant drop from baseline sexual function in prostatectomy patients, more so than you see in radiation. But over the ensuing years, you see a sort of rebound in prostatectomy patients and plateau, while there's a gradual decline in radiation patients' sexual function. But then when we get out to 10 to 15 years, those lines overlap, and again, there's no significant difference in their sexual complaints. Similarly, when you look at urinary control in prostate cancer survivors, again, an early drop in prostatectomy patients, but a slight rebound in plateauing, while there's a kind of gradual decline in radiation patients' urinary function. And then even though these graphs don't look like they overlap at 15 years, there's no statistically significant difference in their urinary control once you get to 15 years after treatment. So we know that patients can have erectile problems and urinary problems after treatment, but it's important to know that there are a lot of options out there for managing these issues in patients, and then every patient should have the ability to access treatments for erections, treatments for urinary function, that can restore their quality of life and help them achieve their goals in their survivorship period. So this is a nice novel tool that was actually created by Dr. John Gore, who's one of the urologic oncologists at University of Washington, that helps patients track their urinary and sexual complaints following procedures and helps kind of compare that to what would be expected or what is seen in other patients with similar circumstances, either similar treatments and similar age. And it helps patients identify what sort of problem their urinary or sexual function is to them and where they're kind of moving in their journey to restoring function. So let's start with urinary incontinence. So urinary incontinence after prostate treatments is rare. You know, you hear people talk about it, but the actual number of patients who we end up treating for urinary incontinence after treatment is rare. And for those who do have bothersome enough incontinence to want interventions, the majority of them are able to be treated with a urinary sling. This is this bottom picture. This is just a small incision, minimally invasive procedure where we place a little sling that resupports the urethra and helps men gain continence. There's no mechanical device. It's rarely something that requires revision, and it can help the majority of men after prostate cancer. For those with higher volume incontinence or have more bother related to their symptoms, the artificial urinary sphincter, which is up here on the right, is a great option and kind of the gold standard for managing high volume urinary incontinence. This is an implantable, inflatable mechanical device that we place in the patient with a cuff that goes around the urethra and then a control pump in the scrotum. And what this does is it allows patients to just manipulate the pump in the scrotum. It releases the cuff, they're able to urinate, and then the cuff refills on its own so you can walk around between voiding with continence. Very high success rates, very high patient satisfaction with both of these. But what about patients with erectile dysfunction after treatment? So our goal as men's health providers is to identify your goal as patients and your goals as couples and to identify what we can do to help you reach that goal. Some patients and some couples aren't interested in regaining erections. They experience intimacy in other ways, and we can work with you to help achieve those goals in those ways. But for a lot of patients, they want to regain erections after treatment, and our goal is to work with you to help you do that. How do we do it? First is education and counseling, and identifying lifestyle and health risk factors that would make it more difficult for you to regain erectile function. These are things like we talked about in an earlier slide: blood pressure, blood sugar control, cardiovascular issues, diet, exercise, like Dr. Wright talked about. These are all things that if you improve those factors, you can improve your chance of regaining erections after treatment. But a lot of patients require oral medications, and these are the things like Viagra and Cialis and Levitra that you see commercials for all the time, and that people, you read about in Golf Digest and things like that. And so, a large proportion of patients will respond favorably to oral agents alone and don't require more invasive or more advanced therapies, either local therapies or surgical therapies. But a lot of people do, and we'll kind of go over what those local therapies and surgical therapies can be. And one thing I want to stress is that if a patient doesn't respond appropriately to an oral medication, there are a number of options that kind of increase in complexity and invasiveness as we go to achieving what the patient's goal is of regaining erections. I think historically people have used these as kind of a ladder where you have to go one by one and kind of get more complex as you go. But I think now we look at it and say, what are your goals and how can we reach that most effectively and in the easiest way for you, such that you don't necessarily need to do every treatment along the way just to get to maybe their gold standard surgical treatments. So this is a typical clinic plan for a patient who comes after either radiation or prostatectomy to discuss management of their ED. We evaluate your history, we do an exam. We do need to do some cardiovascular risk assessment. There are some patients who the oral medications put them at risk for having complications due to their cardiovascular status, and there are other patients who sexual activity puts them at risk for cardiovascular, from a cardiovascular standpoint. So we evaluate that. And then, like I said, we usually start one of these medications. When we see you back, we evaluate how well the medication works. For some patients, it works great. For others, it works, but maybe not enough, and it's not improving your quality of life significantly enough that you want to do more. Sometimes we can change dosage. We can change to a different medication. There's some data there that even though all these medications, the Levitra, Cialis, Viagra, are within the same class, there's different responses to different therapies. Or do we need to try more advanced therapies? And we'll review what some of these other therapies are. So the vacuum erection device is a cylinder that you put around the penis, and it provides negative pressure to the penis. It pulls blood in, kind of simulates a normal erection, and then you put a band that helps keep the blood in the penis and achieve an erection. Another option, I don't want to say a next option, another option is a little medication that you put into the urethra itself. And these little suppositories basically bypass the function of the nerves to stimulate an erection and stimulate an erection without them. Similarly, there's intracavernosal injections. So these are medications that patients self-administer and inject directly into their own erectile bodies and stimulate erection. And I hear a lot of murmurs because it seems not like an enjoyable experience. But the truth is that this is one of the treatments that has one of the highest satisfaction rates for patients after ED. And we teach you how to do it in clinic in a supervised and safe scenario. And the needles are much smaller than they are in this picture. And people tend to respond very well because if there's any nerve damage, this, again, bypasses the function of those nerves and helps bring blood into the penis and cause an erection. And lastly, our gold standard treatment for ED after prostate cancer treatment, is the inflatable penile prosthesis, or the penile implant. And again, this is like that artificial sphincter that we talked about earlier, where it's an inflatable, implantable mechanical device that goes under the skin. It's not visible when not activated. And there are cylinders that go into the erectile bodies of the penis themselves, and again, a control pump that's in the scrotum. And it allows for on-demand erections. And again, this device has a 90 to 95% satisfaction rate among not only patients but also their partners. And so this has kind of become the gold standard treatment for not just post-prostatectomy or post-radiation ED, but also just erectile dysfunction in general. And is always a viable option for just about any patient. So non-responders to medications, people who are unwilling to do injections, or other things, this is a great option for everybody. So I'll just summarize and say, quality of life is something that's very important after prostate cancer treatments. I'm the son, stepson, and grandson of prostate cancer survivors. And quality of life was something that was very important to all of them after treatment, and doing what we can to improve your quality of life and meeting your goals is something very important to us. Thank you.